Hey, I have no problem with somebody raising their hand and like, sir, you're just blowing way past timeline. Sorry.
My bad, sir. I didn't notice.
That's my second TIA in 2 days, so I need to definitely need to get that checked. So, good question at the break. And so, why do we have this timeline as far as 3 hours? And the reason why is within that 3 hours, the body's going to react naturally and start releasing enzymes that are going to start breaking down that clot. And they've just done all the studies, it's evidence-based, which is why it's about 50% that say 3 hours, the other 50% say 4.5, based on your neurology department in your military treatment facility. They'll put out that guidance with what their standard is. So after that 3 hours, so before the 3 hours, it's basically benefit outweighs the risk. When the body starts releasing its own clotting enzymes, as it does, which is why we get a positive D dimer because there's a clot in there, it's releasing fibrinogen and all this other stuff, and it's trying to break that clot down. Past that 3 hour mark, they said if we give TPA, we're going to cause somebody to go and have a hemorrhagic stroke, or any number of reasons, and start bleeding somewhere else, and then their mortality starts becoming much more evident. So it's with any medication across the board. By the way, medications are produced and licensed natural medication from the earth. It all comes down to a benefit versus risk. I mean, you take enough NSAIDs enough times, you're going to get an ulcer. It's just cost versus benefit. So that's that 3 hour window. They've done enough studies to say, if we push it past here where we've caused X number of hemorrhagic issues and didn't help out with taking care of that clot. But that 3 hour mark, everything before, the benefit outweighs the risk. Does that make sense? And there's a lot of that stuff you're gonna have to trade different things with muddying the water with medicine. It can get a little bit wonky. There's a lot of gray area. So just be aware. I mean, it's a science. Again, I remind you that we practice medicine. We don't have it all down to a perfect art. People do die as much as we may have some of the best trained people. So constantly strive to be the best and give our soldiers, sailors, airmen, and Marines deserve it. So, all right, we talked about thrombolysis here. If you're in a bigger stroke center, you may have this capability. Not every place has this. But again, these are these people, let's say that's that massive MCA that we can't give thrombolytics. These people are not candidate for thrombolytics because they're past their point. There's always these potential where they can go in. Right there, expanded treatment window. So maybe if you don't have that, you can transfer somebody and be like, oh, they do that over across a medical center here at BAMC, and we'll send them over there. So usually not time-based, and they can go in there and take care of that clot. These are massive clots, and they're not in the realm of that. There's potential that those people that know what they're doing and they're under that care, they can use lower doses of thrombolytics to help out. If they can identify that clot, mechanically disrupt it, they'll go in there and almost like sneaking out a drain. It's filled with hair or whatever else they got caught. That's essentially how they will pull those out. You can look it up on the internet, it's pretty sweet. And then, there's a number of interventional radiology folks that'll go in and inject TPA right into a blood clot and break it down and not run the whole risk of, because you're giving thrombolytics, that's the problem, is you're giving it through an IV, it's going to affect the entire body. You're involving all the vasculature, but internal radiology can go and inject directly into a clot. They will do that with a DVT, they'll do that with a PE, and they can go in there and fix that. I mean, it's basically what a stent does, right, for the heart. Open that vessel again mechanically. So don't get in the weeds with that. You just need to know if you have that capability or what place does have that capability in the event that you need to. Okay, stroke patients, ideally if you have a stroke unit, most places don't. So needs to be monitored ICU. So make sure that you transfer that patient, make sure they're stabilized, and you do want to get that, if they're in that window, at least get that TPA going, because if you transfer them and they go past their window, then that's not even an option. I'll tell you, some places are a little apprehensive about accepting a patient if they know TPA's already been pushed. Because they're like, well, if this goes badly, I'm eating it. So, but most folks are, have the, want to take care of patients and understand that, get that done. But let's talk about what I've had the past 2 days. So, this is a transient type of thing. These are precursors. There's no acute infarction without acute infarction. So, for let's say analogous, what is this to? This is typically stable or unstable angina. Angina, please call it that way. People will make fun of you. But we want to make sure you have all the risk factors there. But we want to see how long, get an idea if somebody's having these weird types of symptoms where they're coming in, complaining weakness, speech impairment, but it was resolved. If it's going over 10 minutes, we need to be a little bit more concerned. The cool thing is we have this awesome decision tool. ABCD 2 score. No, I'm not going to have you calculate this. No, I'm not. But I want you to be aware that this is a decision tool. This helps me make a decision. Do I need to let my patient go home because they are a low risk? Or I need to bring the patient in. Obviously, age plays a big factor in there. Look at that diabetes again. But it just gives you an idea. You should look at that patient and say, what happened? How long did this last for? And we give them a score of 0 out of 7. Great decision tool. How does that work? I can say ABCD2 score of 0, going home. Follow up with your primary care, or I'm going to put consult in neurology. Awesome. When I pick up the phone and say, hey, I got this lady down here, I think she's had like 3 TIAs today, I got an ABCD score of 5. They're going to be like, okay, cool, we'll be right down. Just quantifies that for them. And by the way, no consultant, if you document in your records that they have a 5, a score of 5, or higher, I'm just saying, anywhere from 5 puts that at 4%, 4 or 5, they're not going to let that go home. That's documented. If that patient has a bad outcome, that's going to come back on them. So it's a great way to kind of windage that a little bit. So you got your 2-day risk, but anywhere to 4 to 5 is a 6% risk. I'm not willing to go down that way. Now that person, they get admitted for TIAs, they're basically going to get a stroke workup. What does that consist of? So if you didn't already, you should have got a CT, but they're going to come in, they're going to get an MRI. They're going to ultrasound the carotids. They're probably going to do an echocardiogram, figure out like what are the risk of embolic strokes versus hemorrhagic. Tune them up, make sure their blood pressure's under control, that kind of thing. And then if they weren't already on a baby aspirin, they're going to leave on one. That's going to help prevent any clot formation. Very important that you get all the information from these people, get all the risk factors figured out, including a full neuro. EKG, most people that come in with any types of symptoms like that and they're over the age of 60, they're getting an EKG. By the time they get back to your room, they should have an EKG already in the wall, in a chart. So again, you get that initial CT for sure. And then MRI, that'll typically be done inpatient. We're not going to hog that up for TIAs. We're going to save that for the actual strokes. So again, I told you Doppler ultrasound is typically carotid ultrasound, looking for any type of clot burden, risk of embolic stroke. It'll break off. So again, these are mostly what's going to happen inpatient. What are we going to give every single one of these patients? Because they're not stroking out, so we're not reaching for thrombolytics, they're going to get aspirin. But if you were to pick an answer and it says one's aspirin, the other one says aspirin plus dipyramidol, you're going to go with that. So that is the best thing, is give them those 2 medications for TIAs. So clopidogrel for your aspirin allergies, because that's what we go with, aka Plavix. So same thing with TIAs. Or if they're out of the window, yeah, you would potentially reach for Plavix if they have that. Warfarin was given back in the day. And then obviously if they're coming in and they have atrial fibrillation, which is why we get that EKG, and they're not anticoagulated, they need to be anticoagulated. They need to be. Just the risk factor with AFib is terrible. But they'll usually start that inpatient. Now we talk about our special populations, our sickle cellers, kiddos, hurts my heart, but they deal with ischemic stroke. Children, very common to have aneurysms, arterial abnormalities. So ideally, we need to treat the underlying sickle cell disease, whether that's with pain control, so that's most of the time. They need to be put on oxygen, usually a lot of fluids. So, and then talking with their hematologist, hopefully their hematologist and not some random hematologist, and a stroke neurologist if we're really concerned about that. Admit those patients. Yes, it does happen with pregnant females. So it is an increased risk because of hypercoagulability and up to postpartum period. Technology says 6 weeks after birth. 6 weeks after birth. So, and we talked about this before. Yes, preeclampsia plays a role in that because that has to do with hypertension. Risk that as well. But that hypercoagulable state happens, unfortunately, with pregnancy. So, can women get TPA? Yes, they can. Yes, they can. But I'm gonna tell you right now, before you push that TPA, not only have neurology on board, I would make sure I probably touch base with obstetrics and just let them know, hey, I got a pregnant lady down here, stroke, and we're gonna push TPA. So, no, it does not cross the placenta. But early consultation, load the boat, get all your people on board, just heads up. And sometimes they may get nasty on the phone, maybe they were up all night. And they're like, what do you call me for? I'm like, I'm just letting you know. You can be there or don't be there. If it's a bad outcome, I called you. So, all those are recorded. All those are recorded. Just remind you that every telephone in the hospital is recorded. So I'm like, you wanna get nasty on the phone with me? Okay. Come down here. I'll show you how nasty I can be. Anyway, got some recap notes if you just want to go back and review, make sure you got the stuff here towards the end of this one. Because stroke's just kind of a lot of ambiguity in there with how those present. Again, based on where that exact clot is it more proximal to where that vessel is? Can have more symptoms, more distal, more subtle, waxing and waning. Maybe they're stroking out in several different locations at the same time. It's not like, oh, they only stroke out at one spot at a time. It can get really, really wonky. All right, so let's get into some, not that. It's a problem with having two monitors now. It's not a problem, but it just gets wonky sometimes. Check on learning. What? Okay, you guys decided about that, huh? Dr. Casimir should follow my lead. So, I know. So don't be mad at me when you take your test. It may be very similar to it, but just pay attention to it. I might tweak a couple little things. Like, for the most part, no, I'm not trying to catch anybody. I'm not trying to catch anybody, but I can't have the exact question. Maybe, whatever, I don't care. Wait a second. Did he lecture at all about A, B, D, or E? Nope. What do you think the answer is? There you go. Cerebellar. I told you, vertigo, nausea, vomiting, difficulty maintaining their balance. That's posterior in nature. I'm not going to throw in there a posterior stroke and a cerebellar infarction, okay? I'm not going to do that to you. So obviously, B and C can't have the same answer twice. So
Delta.
I put that on there because it's just most common, but actually it's vertebral arteries, posterior, right? Posterior vertebral artery. Oh. Oh, man. This one really wrecks the phase 2 people. Can we push thrombolytics into somebody even if they are a candidate for 200 over 110? Hell no.
They're no longer a candidate. You can't go down.
So that puts B and C out. Is patient a candidate for thrombolysis?
No.
Why not?
5 hours?
Out of time window, yeah.
So E?
Okay.
Okay.
So
B.
we're just gonna say we're gonna lower their blood pressure and be like, have a good day.
No, it's the aspirin.
E.
Yeah,
E.
E.
The out of the time windows for thrombolysis is out, but we need to lower their blood pressure. Okay? We need to lower their blood pressure. It's a little bit too high. We're gonna run the risk of hemorrhagic stroke.
Sir.
Sir?
So in this case, when would it be permissible for them to have hypertension? Like when we talk about permissive hypertension with.
For permissive hypertension,
Yes.
so think about that for a second. So permissive hypertension for this patient would be if they were within like a 3 to 4.5 hour window.
Okay.
3 to 4.5 hour window. This is similar to your warm up, or maybe the same thing.
She got to the end.
She gotta make sure we're clear on this.
Minutes before she woke up. That's a fast fucking ambulance. There's something.
We talked about this.
They have a red phone booth inside that ambulance.
I appreciate the reference. Otherwise,
I know the timeline's all wonky there. Sorry about that. All right, either way, aspirin. Man. Third
I got
TI.
hung up on the time. It's like,
Alrighty, folks.
It's that PFC time if you try and fast enough.
you go back in
Nick
time.
gave you some seizures now.
Oh, I've seen this one.
Well,
He seizes.
I love how the title is just seizure.
So just give you some context. This gentleman skydiving in Australia, he suffers from epilepsy. This is his first jump, and he starts seizing up at about 10,000 feet. Luckily, his partner catches up to him and pulls his reserve. He's out cold.
I know, they thought someone else was there.
So, it's a whole thing,
First of all, props to him for being
Maybe
posting
down
and
skydiving
landing
with
who
something.
in their right mind would let somebody with epilepsy go skydiving is beyond me. I guess in Australia, all rules are off. All rules are off. We'll get into seizures here a little bit. No, I will not. We hit time. I'll be keeping track on it. All right. Seizures. Very significant emotional event unless you deal with somebody who has epilepsy, deals with seizures all the time. I say that especially for a kiddo. Have you seen a kid with a febrile seizure? Very significant emotional event if you're a parent. I've dealt with seizures plenty of time. When it's your own kid, kind of a big deal. Febrile seizures a little bit more common. We make sure that they're simple. We'll get into that a little bit, but still significant emotional event. I feel like somebody's been seizing for like 10 minutes when it's really only been like 2 minutes. Tit and Alley, 5 pages. Tit and Alley. Just some concrete evidence for you. Just a couple little pictures to make you think of that. So it's a lot of electrical activity that all happen at once suddenly. Typically comes out of nowhere. So got a lady there. So incontinence is a typical thing that we'll see. How you can differentiate a seizure from other types of things. The other one there is tongue biting. You know, people clench up their jaw. They will bite their lips. They will bite their tongue. Incontinence, and then the whole postictal period. Whole postictal period. Here's your objectives. So here's the deal. Most seizures will stop on their own. Most of those, if they don't go past 5 minutes, we don't need to do anything but protect our patients. If you're in a nice hospital, they have special pads, seizure pads that they put on the side of the gurney and pull the rails up. If you're in a not so great hospital, they come in there with towels and blankets and tape them to the sides. I've been in both situations. So we want to protect them from any physical harm. If they are in a staying position and seized quickly, you might need to get in there and hold some C-spine. Be a good idea. And then first line, obviously benzos. What to reach for, things like chlorazepam, diazepam, work great for that. So, and then repeating doses. I will show you a really cool little algorithm-based deal with that. So, known seizure disorders, not as concerning. They suffer from epilepsy, whatever reason. But other types of things, poisonings. So they had at least 3 different Afghan soldiers that decided they were going to take too much heroin, came in seizing. Pretty exciting stuff, but they had different rules over there. But also be concerned that there's a brain tumor. Also had an Afghan local national that was one of the interpreters, got a meningitis and decided to go into full-on seizure, unconscious. Getting him out of there when the air's on red was very interesting, but got it done. Then he wanted to come back and work with us like the next month. I was like, no. I'm messing with you again. So, we want to make sure that we're not mixing this up with a cardiac event, an older person. Because when they drop from a heart attack, there can be a little bit of twitching, a little bit of agonal breathing that can get misconstrued, observed as a seizure. I want to make sure that. And then you got to think of all these different etiologies. What is your underlying issue that your patient has? So if they're immunocompromised, they have HIV, the chances are of them having a brain infection much higher versus women have seizures for a lot of different reasons. So eclampsia can run to that, a bunch of different things. So be aware of that. There you go. Warm up case. What's the first thing we're gonna get?
Glucose?
Glucose.
Phenytoin levels.
Okay, I wanna make sure, did she seize because she's hypoglycemic, or is she not hypoglycemic since she's seized, and do we need to intervene on that? And then we also wanna just make sure that we get a phenytoin level, just so they can follow up on it again. You're not gonna make a clinical decision this day. She has returned pretty much to her baseline. You make sure that most tongue lacs don't need anything. Most of those will resolve on their own. The mouth heals up very quickly. So we're gonna get glucose on this lady, draw a phenytoin level, and then DC her. She also, if she's known seizure disorder, she shouldn't be driving anyway. Although there are people out there that do that. If this was a person with not a known seizure disorder came in, and they return to baseline, you work them up, everything's good, you make sure you discharge them, they're not allowed to drive. They should not be swimming. What do you think? And no
Operating
heavy machinery or anything like that until they're cleared.
Flying
They're
things.
cleared. I don't figure that out, you can go home, but you're not gonna be driving. And next thing you know, you're seizing and wrecking your car, that's no good, no good.
Would you
There's
do,
your definition. Uncontrolled electrical activity. So usually affects muscle tone and movements. That's why we have this.
for the individual with status epilepticus, would you want to do a pregnancy test or drug test for that person?
For a female,
Yeah, for the warm-up case, would it also be appropriate to do a drug test or a pregnancy
yeah,
test?
they're probably gonna get that from triage.
Okay.
But yeah, if it's female, I'm gonna be safe and cover all your bases, absolutely. But, I mean, known seizure disorder, rest a little bit more reassured on that. As far as it's not gonna be something related else with that, but yeah, absolutely 100% in a person with no seizure history. But yeah, most of the time, most women that come in, that's all gonna be handled through triage. Almost every woman of childbearing age is gonna come in having HCG, to help you out. Good point though, good point. So, here's your epilepsy, that's recurrent seizures. So the brain has developed this lower threshold for that. And then does not refer to people, these are not reversible types of causes. Reversible causes have to do with alcohol withdrawal. So as people start getting DTs, then they run the risk of withdrawal seizures. So your toxins, your hypoglycemic, and any other number of metabolic derangements that typically has to deal with electrolytes. Is your primary idiopathic? That's where we hopefully want them to be. If they're secondary, we want to identify what those are and figure out if there's something we need to do to affect those. Anybody have an idea what that picture is?
Neurocysticercosis.
Neurocysticercosis, yeah. So, usually from eating some raw meat or whatever reason, cause parasites. It's nasty. But if you were to see that picture again, you should know what it is. Okay, and then you have your reactive, whatever reason, usually related to medications, metabolic disturbances, also sharp blows to the head. So not considered a seizure disorder, that's just a reaction, that type of thing. I imagine it happens in the octagon a lot, but whatever. You have your provoked, usually an event within 7 days. Unprovoked, nothing they can really identify that causes that. And here's your status epilepticus, I want you to pay attention to this. So seizure activity, more than 5 minutes. And keep in mind, that's a tough thing because nobody goes, seizure starting and hits a stopwatch. Usually doesn't happen. But more than 5 minutes. And then if they have 2 seizures where they don't ever regain consciousness in between the seizures, that's where we're getting into status epilepticus. That's where the real medicine starts. Otherwise, people are seizing, they're just gonna protect them. And then if they get refractory, that's where it gets real concerning. So that's after they've been given 2 different anti-epileptic drugs, 2 different ones, and they continue to seize. That's bad. Chances of turning them out of that are not good. For the visual folks, here's your classification, your 3 general categories. These generalized. The consciousness is always lost, then you have these partial. We'll break down each one of these so everybody's clear on what these are. And then just be aware that you have this Jacksonian march seizure that only occurs with one side of the body. Just be aware of that. Tonic-clonic, that's your seizure that everybody sees in the movies. That's like every seizure that happens is tonic-clonic. Full on, that's all the shaking. So you see the tonic phase where they're stiff, clonic where they're twitching. Tonic where they're twitching. Entire cerebral cortex is involved. It's infecting the entire brain, which is why it's causing the entire body to react. So these people have loss of consciousness for sure. So it can be tonic-clonic back and forth, but there's usually jerking rhythmic movements. Here's another one good for you. Breaks down the conic versus the tonic phase. So tonic, rigid, clonic, coarse trembling. What happens with these folks is concerning. You always make sure that their airway's not getting involved. These people will have apneic events. Their jaw is clenched and they are not. It's very shallow breathing and can have apneic events with that. We get concerned that they're getting hypoxic at that point, especially if we're going past the 5-minute mark. That's why status gets very concerning. Aside from incontinence, it can also vomit, which puts them at risk for aspirations. So once that stops, they're unconscious, flaccid. They start kind of rapid breathing, but it's usually very deep. Typically only a minute to a minute and a half. Now for the person watching that, that's like an eternity. It's like an eternity. My parents would be like, I was seizing for like 10 minutes. For actually to start a clock, and you'd be like, right in that window. Right in that window. Consciousness returns very slowly. I'm talking like they seized for a minute and a half. It's probably gonna be another hour before they're lucid enough to answer your questions. They're not gonna know where they are, they're not gonna know who they are, they're not gonna be able to respond to anything. That's that post-ictal confusion, which should be the dead giveaway. Like if they're post-ictal, you're like, yeah, they definitely seized. They're gonna be out of it. And then because they had that full tonic-clonic action going, they're gonna be complaining of myalgias for several days. Is there concern for rhabdo? Yeah, absolutely. Absolutely. And then fatigue up to several hours or more. They probably sleep really good that night. Sleep really good that night. Versus your petit mal. So also known as the absence seizure. So very brief, only for a few seconds. So no change in postural tone. So this is not your typical. So it's absence, so you're not gonna have that typical tonic-clonic type of thing. But these people just kind of sit there, look like they don't know what's going on. Potential that they are staring, or they can have some twitches in the eyelids, but they do not respond. It is possible, again, to have incontinence and involuntary movements. So usually stops, goes away. They are not post-ictal. That's why it makes this one a little bit more difficult. This is the school-age kids, where they usually catch this in when they're just doing horrible in school. They're consistently having these absence seizures. I feel like anybody been driving on the highway and you're on like a long road trip and you're doing like 80 on the highway and you just kind of drift off and you're thinking about something and you realize you're driving? No, just me? Okay, good. That's what I would describe that as for these kids, but I've done it a couple times, just kind of zone out. But some of these kids have 100 times a day where they have this issue. So usually as they mature, it goes away, which is a good thing. If they're an adult, we don't really call it that. If they're an adult, it's more likely a minor complex partial seizure. So they don't want to call it absence. So treatments are different. Treatments are different. You have partial focal seizures. So this usually happens in the cerebral cortex. So it can localize, it can expand to involve an entire cortex. Unfortunately, this is usually due to a structural lesion. Structural lesion in the brain is typically the cause of this. Makes you a little bit concerned about that. And then, of course, it can spread to mimic that. But usually no focal deficits. Again, eventually what these people need, if they had a seizure or whatnot, at some point they probably need to see a neurologist. Not probably, they should see a neurologist and they need to get an EEG done. EEG needs to be done. Okay, simple. So consciousness and mentation are not very localized seizure, could just be a little bit of hand tremor, leg tremor. So, based upon where those are, specifically where that activity is, will mimic how it responds in the body, whether that's motor. It can affect visual symptoms, and then crazy enough, olfactory, so it can affect olfactory gustory. So that can affect either smell or taste. Really a wonky thing. Very uncommon, but just, you wear that. So, and then again, it can spread as well. We get a little bit of electrical activity in one area of the brain, it can spread to others. Now your partial complex. This is the weird one. So, consciousness and mentation is affected in this one. So, again, based on where that is, typically the temporal lobe. So these are wonky ones. These are typically diagnosed as psychiatric type of issues. And I'll show you what types of symptoms they have. So a lot of people be like, oh, this person's just, it's a psych issue. It's not an actual seizure. Because why they have things like this. So, if you're ready to get a question on this, make sure you're picking seizure of partial complex, because this person's having some weird type of things. Lip smacking, fiddling with clothing, keep saying the same thing over and over, like Rain Man, whatever. And then you have all these other type of sensory type of differences. And then it gets rolled into this psychiatric type of issue because of all the distorted perceptions and affective disorders.
Would they generally only have a single symptom group, or would they have some of each? Would they have like?
It's typically gonna have multiple. It's typically not just gonna be one of these. They're typically gonna have several across all those.
Okay.
Yeah. So again, your history. Do I think this is really a seizure? Just because they tell me my kid had a seizure, you got to start weeding through that stuff, and we identify that. Were they lose their consciousness? Were they twitching? What was happening? How long did it last for? Things that give that away. Tongue biting, any type of trauma. Incontinence is a huge one. I don't think I've had somebody that was seizing on me that didn't have an issue with incontinence. And almost every single time that I've had somebody that sees, that was an issue. And just have an idea that that's not a mimic. Get all those details about that. Hopefully you have somebody that was there, because the patient's not going to be able to tell you. If they truly had a seizure and they're post-ictal, you're going to wait an hour before you're going to have a conversation, and they're going to have no recollection of what happened. Zero. And they have videos, they take a video of somebody and show them this is what happened. They're like, that wasn't me. Zero recollection. So. Heard some mimics with that. Yeah, maybe somebody syncopized, a little abdominal breathing, arrhythmias. Something called pseudo-seizures. We'll talk about that a little bit. We've got our migraine variants. And then myoclonic activity, whether that's having a dream like you're falling in your dream and you wake up and twitch real quick. Yeah. So if somebody's watching you sleep, not that anybody would do that. They might think that that's a seizure anyway. Questions to ask. Inquire about, hey, did you have any prodrome? That's kind of an aura. I say, do you have any feelings, something felt different before that? Please figure out how you're gonna, I don't say dumb things down, but layman's terms for folks. You ask a patient if you have aura, they're good. Yeah, it's orange, light blue and sparkles, whatever. Abrupt, gradual onset, and then just obviously incontinence is a big issue. Oral injury is very common. But also any other trauma. If that person seized while they were standing, shoulder dislocation, hit their head, anything like that. And then of course that lethargy post-ictal period. Known epileptic, get an idea of how often do you have your seizures? How often do you have breakthrough seizures? Is it because you missed your medication or just what's going on? There's a bunch of different things that go on with that. If you can figure out what the inciting event, that would be great too. Here's your reasons why. Here's your reasons why. Number one, they miss their medication. It's typically more younger population that's dealing with epilepsy. So, but any changes in their medication recently, maybe it's a new one. Sleep deprivation plays a huge role in this. Sleep deprivation. And then any other type of stressors, electrolyte disturbances. Infection is a big concern for that, causing that. And then any type of withdrawal from substances. So it's narcotics, alcohol. So be concerned. I get really concerned about those last three on the list. We can fix the other stuff, but those last three are like the red flags for me. So making sure there's no history of that. Maybe somebody doesn't want to be honest with you, like, I don't want to tell you that, whether I had seizures. Or I would have never been in the Army if they knew I had seizures. So I'm not going to be straightforward. Like, they never saw behavioral health, even though they did. Recruiter helped them out with that. Got to get those numbers right. Unexplained injuries, these are just things to kind of give you a way and help you out. Headache plus seizure, very, very, very concerning. So suggests that there's some underlying structural abnormality, some intracranial pathology is very concerning. So, and then in pregnancy or recent delivery, we need to jump on the eclampsia train right away. So, I said after 13 weeks, that can go. All right, you get that glucose. Check good physical exam, make sure there's no further injuries. Why? Because that posterior shoulder dislocation is easy to overlook. Look in the mouth, just because they down on the tongue doesn't mean that they didn't crack some teeth. So dental fracture, and then if they vomited while they were seizing, there's concern for aspiration, so I'd probably throw a chest x-ray in there for sure, especially on your first time. Complete neuro exam with these folks. We want to make sure that there's not a mimic or there's not some type of deficit. Mostly because we want to make sure it's not this Todd's paralysis. So we're going to make sure that you identify it and that it resolves. So this is this weird thing where they have this focal neurological deficit that should resolve within 48 hours, just secondary to the seizure. All right, this sounds like a great spot to stop. Everybody good with that? Please let me know if you have any questions. We will finish this up